Okay, so welcome everyone to Project Echo Geriatrics. Thank you for joining us on this lovely Friday. I'm Beth Labardi. I'm the resident geriatric psychiatrist on the panel here, and I'm just standing in for Kate Bennett for the week. And bear with me as I do my best in her role. Big shoes to fill. So I just want to introduce our speaker to start off for today. We have Barb Cochrane with us today, which is an immense pleasure. She is the Associate Director and Curriculum Advisor for Nursing with the Northwest GWEC. So that's awesome. She's also the DeTournay Endowed Professor for Healthy Aging and the Interim Chair in the Department of Family and Child Nursing at UW, the School of Nursing. She has research focusing on older women's health and health promotion, specifically the prevention and management of chronic illness and symptoms. She is a joint associate member at Fred Hutchinson Cancer Research Center's Public Health Sciences Division, where for the last 25 years, she has been a co-investigator at the Clinical Coordinating Center for the Women's Health Initiative, a large ongoing study of the major causes of morbidity and mortality in postmenopausal women. So who better to talk to us today about women's health considerations within primary care.
Great, thank you.
Away.
Thanks much, and welcome everyone. I do want to sort of offer a caveat that I'm not a primary care provider, but I have been steeped in women's health for the last 25 or 30 years, and so what I'm going to present today is a little bit of a potpourri of updates and considerations related to women's health, and I hope some of it's of interest. This is not.
Just right click.
You can use the scroll wheel. You can use arrows. I don't know what's going
Okay. So I have no disclosures other than I just raced over here from the main campus. And I'm going to talk a little bit about the context of older women's lives. These are the women who are coming in to see you in your clinics, and there's a lot going on for them. A little bit about chronic conditions, and just to give full flavor to the work I've been doing for the last 25 or 30 years, a bit about hormones and the findings from the hormone study of the Women's Health Initiative, and then just some considerations related to primary care encounters with women. To set the stage of the context, as you know, we actually have a larger percentage of older women than older men, and what that translates to is that we have a larger percentage of older men who are living with a spouse or partner, and a smaller percentage of older women who are living alone because their spouse or partner is no longer with them. And so what happens for these older women is that they do not have the kinds of caregiving arrangements that we might see for older men. This also just shows some differences between men and women in terms of chronic health conditions. And the things I would want to point out to you is that if you take a look at this, these charts, the incidence or the prevalence of heart disease is higher in men than women. The prevalence of hypertension is a little bit higher than in women, as is the prevalence of arthritis, but some other common conditions that you see in the primary care setting for older women are slightly higher in men than women, but there's some interesting considerations regardless. So I'm going to get into that. And then this just shows the percentage of non-nursing home or more community-based men and women 65 and older with dementia, and you can see that we have a higher percentage of older women than older men with dementia in the older age groups. So hypertension, about 32% of women in the US have hypertension, and it's actually more prevalent among older women than older men. And death from coronary heart disease progresses increasingly and linearly as blood pressure increases, such that for every 25 millimeters of mercury systolic or 10 diastolic increase in blood pressure, we see a risk of death from CHD doubling. And so hypertension is an important consideration in chronic illness for older women, and particularly coronary heart disease. It is the leading cause of death in women overall, even though we see more a higher prevalence of cardiovascular disease in men and women. Half of all CHD deaths each year are in women, and the prognosis may be worse for women than men once coronary heart disease manifests, and that's generally because women are about 10 years older and have more comorbidities and risk factors when they have manifestations of heart disease. But it's important to note that we see women presenting more often with angina than with MI in their older years compared to men. Women are often underprescribed discharge medications, including aspirin and beta blockers. And although it's getting better, traditionally some of the other interventional therapies have been, treatments have been provided more to men than for women. And then strokes, although they occur more often in men than women, women are more likely to die from stroke. And I wanted to mention, because I think this is relevant to primary care, and a lot of this work has come out of nursing, what is an MI really like for women? We think about the traditional crushing substernal chest pain of an acute myocardial infarction, and certainly that is still one of the most common symptoms that we see in women, but we actually see more often than in men that MIs will begin with some very vague symptoms. They may be symptoms that go on for a month or more before the MI, and then they slowly intensify. Their pain or discomfort can start out relatively mild. The symptoms may come and go. They may be more likely to have something like a jaw ache, or just even a sense of danger or impending doom. And so it's important to stay tuned into those signs. When I did my dissertation research, I was interviewing women post-MI, and the stories that they would tell about going to the ER and being prescribed Mylanta for chest pain, and then having to come back with cardiac arrest or something like that, because it is just not the typical symptoms that you might see in men. Another thing that's important to note about coronary heart disease in women is that if they have diabetes, it confers a risk that's about, that sets, for example, younger women at a similar risk as men. So diabetes affects about 9.2% of all women 18 and over. A good 2.5% have undiagnosed or they're not aware of their diagnosis of diabetes, and women are more at risk for ketoacidosis. So it's something to really screen for in older women. There's a higher percentage, as with men, of racial ethnic minority women with diabetes compared to white women. But again, as I said, diabetes can confer quite an increased risk of CHD, MI, and stroke in women, and women with diabetes are more likely to die from an MI or have a recurrent MI. Some facts that I just want to convey about cancer in women is that the top killer for women from cancer is the same as for men. It's lung cancer. It's greater than the risk of breast and ovarian cancer combined, but breast cancer is the leading diagnosis, and in fact, from age 70 to over, 1 in 15 women might be diagnosed with breast cancer. Colorectal cancer rates are slightly lower in women, but it's still the #2 cause of death, cancer death. And similar to men, the risks for lung cancer include smoking or asbestos exposure. And one of the things we've been dealing with in women's health, it's getting better now, but we were seeing a real uptick in smoking in younger women, such that there were, that the smoking rates in men were dropping, but we weren't seeing as much of a drop in smoking rates in women. That's fortunately getting better now. And then just because I need to be able to talk about the study that I've worked on for so long, I just want to give you some updates about menopausal hormone therapy and health outcomes. Some of you may know that the Women's Health Initiative hormone trials involved about 27,000 postmenopausal women between the ages of 50 and 79 across the United States. We started out in 1993, and the study were stopped suddenly in 2002 and 2004, depending on whether they were taking a combined hormone preparation or estrogen alone, because of increased risk. And this paper represents a sort of an examination of the findings both during the intervention as well as the post-stopping period to give us a better sense. And so I just thought you might be interested, because I was attending a conference just this last week in which somebody was a little bit confused about what the Women's Health Initiative hormone trials showed. And so I do want to point out that we see with the combined hormones, which is estrogen plus progestin, an increased risk of breast cancer, both at the intervention and the post-intervention phase. But we see potentially a slight decrease in risk associated with estrogen alone. We see increased risk of stroke for both preparations. We see an increased risk of pulmonary embolus if a woman is taking combined hormone preparation, and you probably know that the reason a woman would be taking a combined hormone preparation is to protect her uterus from endometrial cancer. We do see a decreased risk at the intervention phase for the combined hormone therapy preparation, but that did not seem to continue on in the post-intervention phase. We see a profoundly decreased risk of hip fracture related to osteoporosis, but there are now so many other preparations available that estrogen is really not first-line therapy for the prevention or treatment of osteoporosis. And one of the reasons that the trials stopped was because this sort of global index of all the risks and benefits of these preparations showed increased risk for the combined hormone preparation. And so the summary of this for the hormone findings, and this is relevant to older women because the Women's Health Initiative, when it was first instituted, was done with the idea that all women in their older years should be on hormones for the rest of their lives to protect themselves against coronary heart disease. And what was found is that use for chronic disease prevention was not supported. It was associated with increased risk of stroke, venous thrombosis, as well as other kinds of conditions like gallstones and urinary incontinence. And one thing to point out is that another sort of discussion that I have with providers is that there's been a thought that estrogen is an appropriate treatment for urinary incontinence, but the studies actually show that it doesn't help and can make things worse. And you also may have heard, it wasn't part of our main study, but there was a thought that hormones were going to protect against the development of dementia, and that did not bear out either. So hormone therapy is now viewed as more of a reasonable option for short-term management of moderate to severe menopausal symptoms, but in younger women, in other words, women who are near the menopause, and that caution really needs to be exercised in older women, even if they're having vasomotor symptoms because of the high risk of coronary heart disease and other outcomes. So the combined hormone therapy risks outweigh the benefits regardless of age, particularly if it's longer term. And for estrogen alone, the risk to benefit ratio is maybe more favorable in younger women. And what this means for you in primary care, all of this is that it's really important to assess for common health conditions, including thinking about those that are underreported, because it doesn't always occur to women that urinary incontinence is not necessarily a normal happening with aging, and instead is something that can be addressed. But it's important to know all of that as you're starting to juggle what kinds of treatments for managing the symptoms. It's important to promote screening and vaccination, even in older women. A lot of the screening guidelines are now being revisited and changed and are not set so much up as an age interval, but instead how a person's health is, and whether their life expectancy would justify treatment if they're screened positive. And then the importance of promoting a healthy lifestyle, because in spite of everything that a person might do, just modifying a person's lifestyle in terms of diet, exercise, less sedentary lifestyle, and stress reduction can have a major impact. Some estimates are as much as 70% on lifespan. And as you're focusing on women, build on their strengths, because they are, based on the work that I've done, really an important source of strength and support, not only to their families, but it's important for them to recognize those strengths in themselves. And I think I'm done. Yes. How was that?
Wonderful.